and I invite Dr. Benny to tackle if community programs for obesity are enough, or are we treating obesity too late? There is one.
Good evening, all. First of all, I thank Dr. Jothydev sir for inviting me to speak on these community programs in India. And also I thank Dr. Jothydev for supporting AIAARO activities in Kerala. Actually, we have done a state conference, and also we are doing a lot of community outreach program based on the AIAARO. Last week also we have conducted one school health program, mainly targeted on the adolescent girls. So today's topic is community health programs in India. Are we doing enough to prevent obesity? That is the question. And also, are we treating it too late? So obesity, we all know, it is a global public health burden, not only in India, this is a global public health issue. So almost all countries are burdened with obesity. So rapid rise in obesity in both men and women in India also. Almost 50% of the adult women are overweight or obese, and also need a very structured intervention strategies for the prevention and control of obesity in India. We have lot of community health programs targeting on obesity, its prevention and control. Mainly the National Program for Prevention and Control of Non-Communicable Disease, that is NP-NCD, and also the School Health Program under Ayushman Bharat, and Fit India Movement, and Eat Right Indian campaign, and also lot of agencies, especially the ICMR Nutrition is coming up with a lot of guideline, which is very updated with the recent research and also the findings from the ICMR scientists. And also AIAARO Kerala chapter is also coming with AIAARO national chapter is also coming with a lot of research on obesity, and also distributing that research in various forums, especially forums like this. It is a global convention which is happening annually in Kerala. Regarding the NP-NCD initiative, what is the role in obesity prevention? Actually, the NP-NCD, the National Program for the Prevention and Control of Non-Communicable Disease, it is one of the major program happening in India, but it is mainly targeted on the detection and treatment of non-communicable disease rather than the risk-related prevention. That is mainly targeted on the diabetes, hypertension and cardiovascular diseases. Actually, the hypertension and diabetes and cardiovascular diseases are treated with a nominal cost or with medicine which are available in the government sector. When the national, that is NP-NCD is concerned, in PSC, CSC, there are a lot of medicines are available for the treatment of non-communicable diseases, but most of the medicine which are not rational, because now we are the 90% of the diabetes are type 2 diabetes. That most of the diabetes with the type 2 diabetes are obese, but the medicine available at the government sector or the NCD program is mainly the obesogenic, like the insulin, sulfonylurea like glimepiride, and also the obesity neutral one like metformin. There is no option for obesity. That is medicine which act to reduce the obesity problem is not available at the NCD program at the government level. This is one of the main issue when we are taking the program as a whole in the national program for the control of non-communicable disease in India, that mainly focuses on the lifestyle diseases and also community-based screening for hypertension, diabetes, and not the obesity, but mainly targeted on the diseases. But obesity is a disease, but they are not mainly focused on. Health promotion and lifestyle intervention is also a part of the non-communicable disease, but challenges in implementing national program for the control of non-communicable disease is very much, because most of the areas in India, like the rural, hilly, tribal, most of the areas in India, the program is not at a desired level of implementation. Another program is a school-based intervention. So mainly the midday meal scheme under Poshan Abhiyan program. The midday meal program, which is mainly targeted to improve the nutrition status of the undernutrition school students, but mainly the focus is now on the portion control model, that encourages more of non-obesogenic diet and food habits. So now the concept of old cereal model to the new portion control model is one of the targeted approach in Poshan Abhiyan at the midday meal school, midday meal scheme model. Then School Health Ambassador program is another program which run to show the importance of health as a perspective of well-being of Indian, and also the perspective of growth as a whole. Then the importance of early education on nutrition and exercise at the school level. Now the school is congested with the studies, but we want to focus on the healthy children, because the obesity starting from the school life may carry to the whole life with a burden in the form of different diseases of non-communicable entity. But we have to start some nutrition plan and eating plan from the school itself. Like we have to give break for the food, the fruits break. That is in between you have to give some break for eating fruits. But now we are giving only fruits break for having some bakery items from the school canteen. So we have to change that concept to fruit break. Then the parents are forced to give fruits to that students, and they will utilize as an opportunity to improve their health. Then role of Asha and Anganwadi workers. They are the pioneers in managing small children up to 6 years of old. So when we start the feeding from these 0 to 6 years, we have to focus on the primary school, that is Anganwadi children should be managed with a correct nutritional guideline, because they can try to encourage the parent to give some fruits or like nutritious diet for their children when they come to the Anganwadi. And also the ASHA workers can go to the field and assess the various obesity pattern in that their focused area. And so the Anganwadi workers and ASHA workers can play at the root level for improving the nutritional status and also the reducing the obesity burden. and also they can do the growth monitoring in children and also community mobilization effort. Then lifestyle campaigns like Fit India program, Yoga Day and Walkathon and Health Meals. The Fit India program was started in 29th of August in 2019. But on the sports day in India, but that was focused mainly on the school children and also the entire population of the India. But it is now reaching to a particular level of level, like the most of the schools are now forced to implement the yoga and other some programs related to the Fit India. And also the health and wellness clinic in urban area and other areas of India, like more than 1 lakh health and wellness clinic are now working in India, mainly focused on the old PSCs and sub-centers are converted into health and wellness clinic. Now it is mainly focused on healthy habits and healthy lifestyle habits and also the eating habits. Health promotion and NCD screening is happening through the urban health and wellness clinic. Scope for diet and physical activity counseling and need for trained staff and infrastructure. But most of the health and wellness clinic lack of trained staff and infrastructure. Also, we have lot of nutrition focused intervention like Eat Right India, FSSAI food labeling regulation, millets and healthy eating promotion, like that. Are this program reaching the grassroots? But the accessibility issues is in the rural and tribal areas. Health literacy and language barriers are there in many areas, and cultural beliefs and stigma is still with obesity. Most of the Indian population in the rural and tribal area believe that the obesity is something healthy. So the cultural habit and beliefs should be changed in a better way. Then most programs still after disease on the we normally go for reacting the obesity after getting some disease, not before that. So need for stronger preventive framework and international best practice we can adopt, like 5210 campaign in US, like 5 fruit serving, less than 2 hours of screen time, 1 hour exercise and 0 sugar, and school-based BMA reporting, and community gardens and food subsidies. Community participation, there is a missing link, and challenges in tracking obesity, and policy gap, lot of policy gaps still for implementing. Progress is slow but steady. Prevention effort needs scaling and recommendation. Launch a national obesity prevention mission. Strengthen school and workplace programs. Better monitoring and evaluation. Invest in awareness and counseling. Thank you.
Thank you so much, sir, for that very wonderful overview on if community programs are really enough or should we do more. So moving on, I think we can initiate the panel discussion. We have a very dynamic panel, as you can see. They are all either part of the National IRO, the All India Association for Advancing Research in Obesity, or the local Kerala chapter, and we have a global expert as well. So really thankful for this, Dr. Jyoti sir, for putting this together. Let me begin with Dr. Polina. Ma'am, so do global obesity guidelines today, do they really come through, or do they see us through translating into, real world scenario across diverse populations and healthcare systems?
Dear colleagues, today I challenge you to look beyond the pages of clinical guidelines and ask, are our global guidelines truly changing lives in the real world, or are they falling short? Especially across the wide diversity of nations and cultures. Obesity, actually the answer is short. Obesity is not just a statistics. It's a growing emergency that touches every continent. By 2030, over 1 billion of people are supposed to live with obesity. Fortunately, the story is not the same everywhere. If we look at the most discussed country, United States, despite leading age guidelines, over 40% of adults are obese. And they have a huge disparities in healthcare access for Hispanic Americans and Black populations. The opposite situation, the happy story, are reported from Japan. Their national programs really work, and in this country, they have one of the lowest rates of obesity among developed countries. In Mexico, they are facing one of the world's largest childhood obesity. The government introduced a sugar tax and warning labels on junk food. But yet they have some challenges, and the future will show us the results. In India, well, you know the situation much better than me, but judging by what I can see from the discussions at this conference, other conferences which I have attended, and publications, I understand that you have a surge of obesity due to lifestyle changes during last decades, and I'm happy to see that you are already implementing important steps, as the previous speaker have shown wonderful ideas, and as I understand, some of these steps are already implemented here in India, and I would say that I envy your country, because in Russia maybe the situation is not changing so rapidly, but unfortunately I would say that our government is not making much steps forward obesity. In my country, we have relatively good health service for patients with diabetes and obesity. This is covered by insurance and a lot of possibilities. But as long as a patient has just obesity without complications, unfortunately, it's not covered by insurance, and it's mainly considered a health, like lifestyle issue. So it's individual problem. You are failing your lifestyle. That's it. The only good thing in my country is that we have growing availability of GLP-1 agonists. So while the patient is already diagnosed, in my practice I use it very, very widely. We have robust evidence-based guidelines from the WHO and other bodies, and they call for early detection and intervention. It may sound as just words, but in my opinion, it is the most important steps to fight global obesity problem. Intervention. While a patient has already developed obesity, we need to use medications, and it's a very difficult problem. It's much more important to prevent obesity, to change minds while the patient is not yet obese, but already has unhealthy lifestyle and maybe a little bit overweight. In this situation, nobody will tell. If you come to a doctor, he would not discuss with such patients that it is a problem, but it is a problem, and I'm going to tell more about it in my next speech after tomorrow. Our guidelines also tell us about lifestyle and behavioral support, about medical and surgical options for high-risk patients, and of course policy changes to food systems and urban design. All these steps are really important and sound perfect, but implementation is not perfect at all. In the UK, the NHC offers weight management programs, but a long waiting list prevent many patients from getting this care. In Brazil, community health workers deliver tailored advice, but lack of resources and training limit reach to this help in remote areas. In my country, as I already told, if a patient has just obesity without complications, it's his or her personal problem, not covered with insurance. Many countries lack funding or infrastructure to deliver comprehensive obesity care. There is cultural disparities. On one hand, standard BMI cutoffs may be not insufficient, may misclassify risk, like it was already told by previous speakers and beautifully shown, how it doesn't work in the Asian population especially. Another problem in some cultures, people may not consider obesity as a problem. Probably somewhere in some regions in your country, being a bit fat is a sign of prosperity, and being thin may be even a sign of being unhealthy. In my country, it's not so now. It used to be maybe 50 years ago, but still many people don't think that it is a problem if you are a bit overweight, for example, and you are moving to obesity.
With you that, definitely I think there's increased awareness, and then there is intensive approach to screening and intervention as well across the geographies, but yes, we definitely need to do more. So can we move on, or would you like to add to this? Should we move on to the next question?
You mean next speaker?
Yes.
Yes?
So that we get a flavor of everything together.
Yes, I'm speaking too long, I'm sorry. What I wanted to conclude, I wanted to say that obesity is a real global fire, and it demands creative, culturally sensitive solutions. Our guidelines are only as powerful as our commitment to follow it, and let's move from words to action. When I have more time, I will give some thoughts about the actions. Thank you.
I think that's a fantastic note, words to action. And let me move on to Dr. Banshi sir. So with action, we are in a very progressive era today where we have options for pharmacologically treating obesity. But despite that, and despite all the clinical evidence that has been generated, there's a lot of hesitation using the AOMs by healthcare providers. What do you think? Why is that so, and how can we address that?
So it's a very important question that, a lot of anti-obesity agents with a lot of clinical evidence which are available, but still not used by a clinician and is a choice of therapy. So I am putting here the cost is a one challenge, but let us put that, person is affording and he had come primarily for the consulting for obesity. One, many times we don't start talking about the obesity. Suppose person had gone to a cardiologist or a gynecologist or an orthopedic surgeon, his primary intention is not to talk about the obesity. He had gone for one particular condition or one particular problem, and the person dealing with him may or may not knowing about these anti-obesity medication, he will not talk about that. Now, a primary care physician, let us understand that he is going on a primary care physician. he may not be aware about so many new advances, and he is worried that if he will start writing, I am not talking about the cost is not a challenge, but still he will not write it because he may think that, he may not know about all those effects and side effects, and person may feel that, I am writing for it. Now a person is going dedicatedly only for a consultation for his managing weight. Now he may go to 3 different type of persons, either to a person to whom he feel or she feel that she is a obesity specialist, consultant, maybe endocrinologist, maybe diabetologist, maybe metabolic physician, maybe a bariatric physician or a physician, where he may or she may think, where the consultation will decide, and that is the biggest challenge if they are not writing them an anti-obesity medication, because they are supposed to write. A person had also come for the consultation for primarily for that. Second, they might be going to the nutritionist, where they don't want to prescribe them these drugs which are actually having more clinical evidence, but they want to push them on a basis just to change their lifestyle and giving them low carb or pushing them something else. And then they are going to the quacks, which are weight management clinic, which they have started, where a person may just see the advertisement and they may go, and they may use these drugs also, even without, they can't do it ideally, and still they are doing, they don't know the effect and side effects, and they are actually creating more problems to the persons because they don't know the side effects, they don't know what is the effect, how to start these, how to educate the person on these medication, and then they go back and then they say, no, last time I have taken with somewhere and I will not take. Or sometimes this media, because anti-aging medication lead to heart attack, that sort of a thing, and someone died, a film star and a movie star, and next the press is writing something else. So that's a challenge. So how a person who is a consultant, who is a metabolic physician, bariatric consultant, should consult the patient, what is the reason why they have come, and at the same time he should also increase the awareness in the society and his colleagues who may not be practicing primarily obesity, but they see a lot of patients, a orthopedic surgeon, a knee replacement surgeon, and a spine surgeon. They should talk about the obesity. That's a major challenge for them, and rightly they should refer the patient also for the management of obesity. That should be the primary aim.
Absolutely.
And that is what we are doing in AIAARO, You
Correct.
and me have a part of it. Mahendra is the president, doing a lot of activities, trying to increase the education and educating the other primary care doctors and other consultants that they should talk about the obesity. It's an important disease. It should not be considered as just a health condition. Rather, they should talk about that as a disease.
So,
Component is probably more important than medicine or diet or exercise, and that is integrating a smart technology. And the technology will keep on motivating the person. It can be a wearable device monitoring the sleep, the physical activity, the resting heart rate, the calories burned. And this is a constant source of inspiration for a person who is intending to lose weight. And when they lose weight, because of the imbalance between the leptin and ghrelin, the satiety hormones and the hunger hormones, they tend to again regain the weight. And to prevent the regain, it's again critical that the person should be trained on using a smart technology. So not only there should be multiple people from multiple disciplines, there also should be aid from a smart technology. And one technology will not work for all the patients. It should be individualized. And now in this 2025, we are in an era where we have recognized obesity as a disease globally. And even in India, we have more than 40 to 45% of our adults who are obese. And the good news is obesity has now become a treatable illness. Unlike in the past, it is now a treatable illness, and there are medications. Of course, medications are integral, and the theme of this year JPEF is weight matters. So weight matters. If you focus on W, there is a weight written on the W. So weight matters, and that indirectly implies that we were waiting for some therapies to reach India, and that matters a lot, and those therapies have now reached our country. So now in this 2025, we are in an era where we have recognized obesity as a disease, opening the doors to multiple complications and more than 250 serious illnesses. And in 2025, we are in an era where obesity has become a treatable disorder. Thank you.
Sir, but we know that you... Yes, please.
Yeah.
Yes.
Dr. Engage Singh.
So here, sir, there is a peak here. Last week I was at the T1 domestic airport at New Delhi. There is a huge advertisement here saying it is not our fault. We know now obesity is a disease. So when, sir, we are talking that it is not our fault, yes, sir, this is the at T1. You will see that. So here is a huge advertisement saying that it is not our fault if I am obese. So I think this is very, very pertinent question how the lifestyle things are matter. When it is not our fault, then you take whatever you want, then you talk to your doctor, but basically the motive of that advertisement is selling the drug, that we know. So that Banshi, you must intervene for that.
Sir, but...
From the organization, it will help more because
I agree.
when there is a written Lily, the person will Google it and they will find that because they are making an anti-obesity agent, it may have the impact which may be less in compared to if they are just writing that obesity. Yes, exactly.
Sir, but then there are motorcycle rides being organized for obesity awareness. I think they
Obesity
completely beat the
statement, even if it
purpose.
is written like this.
So,
we
a
know that
lot of...
now obesity is a disease, but not by the Lily. The
Banshi,
advertise
sir.
cannot be. That is what I am saying.
Sir, so we have the RO, the core committee here, at least partly. Sir, would you agree that, it's better that obesity associations take lead in creating awareness in the correct scientific manner than leaving it to, pharma companies or so? Because last week in Mumbai, I read about Novo Nordisk, organizing a motorcycle ride for a luxury motorcycle ride for creating obesity awareness, and I think that completely beats the purpose. So whether it's this hoarding by Eli Lilly or that by Novo Nordisk, I don't think it's the pharma companies that should be. I mean, this is my personal opinion, but all the stalwarts are here. I would invite a comment from them.
I think society should take this on us, not the pharma companies. Yes, they can educate clinicians how to use it and helping us.
Maybe we should take the lead in increasing obesity awareness rather than,
making the protocols.
everybody
and,
else.
So I think talking about the question which we continue using the anti-obesity medicines, it is very difficult actually to monitor these patients. The compliance is the most important part. I use Monjaro for say 2 months. I lost 8 kg weight. I gained 4 kg, but I lost 1 kg muscle mass also. That muscle mass I'm not able to gain back even though I'm doing exercise. I was eating good amount of protein and I was using the negligible part of medicine, not like full dose to reach my target. So I think measuring the muscle mass, everybody is not having the body composition machine or DEXA scan in their clinics, and if they use this medicine, they lose their muscle mass, bringing them to sarcopenia, and once they regain weight, they'll gain more fat and not muscles. So I think we will be putting them at more risk. So we need to educate them that those who are doing good exercise, taking good amount of protein, if we monitor that and then giving medicine, it will help.
Great. So, Dr. Jyoti sir, I'm sure being a technocrat, you are always going to feel that, we are not using technology enough, like you just mentioned, to support efforts for losing weight. So, do you really feel that the behavioral modification tools are underutilized and, there can be some more reinforcement? So you did express your opinion on that, but how do you suggest we go about using validated tools?
I think this is a highly relevant question on how to use the digital solutions and tools. Our National President of AIAARO highlighted a very pertinent point, and that is losing the muscle when you are losing the body weight. And whatever is the modality for losing the weight, whether it is diet or exercise or surgery or drugs, there is a approximately 30% weight loss which is attributable to muscle. So when you are losing 100, 30% plus or minus 20 will be muscle loss. That is very crucial, and that is wrong. That is bad thing to happen, and that is again when such digital tools will be helping the person to regain the lost muscle mass. So they should be having the muscle strengthening exercises. So there are tools available which will be referred to and which will be prescribed preferably by the treating doctor. And these tools are meant for not only this motivating or monitoring the vital parameters, but also to ensure that there is adequate physical activity, and they should be strengthening the muscle, not just one muscle, it should be in different parts of the body, and that is very, very important. I saw Dr. Shaini was actually demonstrating how you should be repeating the body composition analysis and also recollecting the paradox shown by Dr. Mahendra comparing his body composition analysis with Dr. Banshi Saboo. And these are all very important parameters to be considered where technology will have an aid. And when to use and which technology we cannot discuss in public, but there are startups also in India now. A couple of startups also are there, and they have also approached us on how they can work along with the doctors, along with the interdisciplinary team, and how we can also help our patients. Because not all these apps will be equally helpful with all the patients. You should assess the patients initially. The younger ones who are very keen to lose weight, they are the ones who are sitting idle most of the time with their mobile phones, and they will be very comfortable using those prescribed apps, and it will be successful also. So choose the right person who can successfully use that digital tool along with the medications if necessary, and that is very important for maintaining the lost body weight and also maintaining the muscle mass.
Excellent. Thank you so much, sir. Dr. Anita, ma'am, so with all this discussion, it's becoming clearer that we need our physicians to be adequately trained in using, in treating obesity. For all these years, we even complained that diabetes was not given the importance at the undergraduate or postgraduate level as well. But now, actually, obesity is coming to the fore. We have Dr. Anita here, who is an American board certified for obesity medicine. But that's, N of 1, and all the stalwarts here with all the expertise and experience. But, really, what is it that we can do to increase that part of obesity, not just as a lifestyle disorder, but as, a disease and management and evaluation in the training programs?
So Purvi, just I wanted to tell you that none of the medical education curriculum, they have incorporated obesity in their undergraduate or postgraduate program. So it's very important. That's one of the reasons that the physician or primary healthcare worker or a healthcare profession is not in a position to treat this epidemic of obesity. So that's very important. Secondly, the most important thing is awareness. Okay, so for example, actually the redefinition of obesity, which was told to us by Dr. Mahendra. So BMI is not the criteria. New terminology, no way of detecting obesity has come. What is central obesity? What is clinical obesity? What is other type of obesity is coming into importance, and that's very important that we should understand. Thirdly, the thing is, now also majority of the doctors, they feel that the disease is a lifestyle problem. It is a cosmetic problem, and it is not a chronic illness. So they also take it for granted. In case somebody is diagnosing it as obesity, they don't have centers to refer the patient. That's also a very important question. So the need of the hour is a CME thirst, where we need to focus on obesity programs, especially the CME's online education, and we need to have association of many societies like Research Society of Study of Diabetes India. We have to take many other organizations, APA, Endocrine Society, and also IMA, and also AIAARO, which is there in practice. And we have to, the most important is the government should take initiative to include obesity in undergraduate program. And as said, as Dr. Banshi has said, so he said every medical college in Gujarat is going to have a dedicated type 1 diabetic clinic. Similarly, every state, every medical college in India should have a obesity clinic. Only then it is going to materialize. Okay, otherwise sitting at home and we want to treat obesity, it's not a thing that can happen.
Right.
So it is more of awareness, and most important thing is there are many quacks and other people who are projecting themselves for treating the obesity, and they spend a lot of money, and at the end of the day what's happening? They do not know, they don't have any trained people, and if something happens, the burnt has to be taken by the physician, and in their presence, if something happens, nobody is there to blame on them. So awareness, education, and incorporation of obesity in the curriculum, that's all we want to say.
Super, very well said, ma'am. Actually, sir, we are running out of time. We have... Thank you,
You
sir.
are talking about lifestyle, modification. One important thing is sleep.
Absolutely.
Sleep disturbance can cause obesity because of the leptin decrease, ghrelin increase. So I think
Absolutely.
that point also, because Jothydev was talking about lifestyle modification, includes sleep. That's what.
Completely agree.
Many people may not know because they are sleeping now.
Excellent, sir. Thank you for actually, bringing up this very important point, very important for adolescent obesity as well. That brings me to my last question to Ms. Geethu. There are a lot of black box warnings on, certain food items which are not so healthy. But do you really think they are making a difference, or they are just like the cigarette smoking is injurious to health, and we still see people, a good number of people still indulging in that? So do you think that it is just an eyewash, or?
So I would say it has an impact on people's behavior. What happens is we are living in a country where there is a supply of unhealthy foods and all. So if there is a labeling like black box labeling or something like that, at least it can influence the consumer's purchasing behavior. At least they would rethink whether to indulge it or not, whether to keep it in the cart or not. So to some extent it will definitely influence or combat obesity, but we should be realistic. We know that there are other factors which can cause obesity, so we need to consider that also. If we can these labelings, if we can integrate with other awareness sessions or other public policies, it will definitely give you meaningful outcomes, because it has seen impacts in some countries where they implemented this, like Mexico and Chile, where they found that there is a reduction in the indulging of sugary drinks and other unprocessed foods. So definitely it will have an effect, provided it should be integrated with other factors.
Great, but in fact we need you and Shiny and Cheryl and everybody, all of you to take the lead in creating more awareness on food labels as well. So the black box warning will help, but food label reading and knowledge around that is also going to be very helpful.
Exactly.
So I thank this really esteemed panel of experts and all the important contribution we got from the audience today for a very successful JPEF-AIAARO symposium. And thank you, Jyoti sir, again for this esteemed opportunity.
Thank you to all of the speakers and panelists for your thought-provoking insights. Let's pledge to lead the change in how we treat and talk about obesity.